Good morning, student. Today's lecture is on the hip joint. Competencies for the today's lecture are: describe the type, articular surfaces, capsule, synovial membrane, ligaments, relations, movements, and the muscle producing it, blood and the nerve supply of the hip joint. Describe the clinical anatomy of hip joint, especially the fracture neck femur and dislocation of the hip joint. We all know that the primary function of the hip joint is to support the body weight in standing position. Also, it helps in transmit the forces during the movements of trunk upon the femur during running and the walking. Classification of the hip joint or the type of the joint is: it is a multi-axial ball and socket type of synovial joint. Why it is multi-axial? Because the range of movement is possible in all the directions. And this occurs because of the long and the narrow neck of the femur. And this long and the narrow neck of the femur makes an angle with the shaft, that is the neck shaft angle or the angle of inclination. In this diagram, you can appreciate this is the angle of inclination between these two axes. The one is passing from the neck of the femur and the one is passing through the shaft of the femur. We will see in detail about it in the next part of the lecture. But the range of movement of the hip joint is restricted because of its role in the weight bearing. The bones which take part in the formation of the hip joint are the hip bone and the femur. Articular surfaces are head of femur, which articulates with the horseshoe-shaped acetabulum of the hip bone. Head of the femur is spherical in shape and it is covered by the articular cartilage except the rough part, that is the fovea, which gives the attachment to the ligament of the head of the femur. In this diagram, you can nicely appreciate spherical head of the femur, and in the center there is a fovea, that is a rough bit. The articular cartilage which covers the head of the femur is thick in the center and thin at the periphery. Acetabulum of the hip bone shows three features: a horseshoe-shaped lunate surface. Here you can see the horseshoe-shaped lunate surface. It is covered with the articular cartilage. This articular cartilage is thick and wide superiorly, where the maximum body weight transmitted to the femur. Then there is an acetabular notch. This acetabular notch is breached by the transverse acetabular ligament and converts the acetabular notch into acetabular foramen. Then there is an acetabular fossa. Here is the acetabular fossa. Depth of the acetabulum is increased by the acetabular labrum. Acetabular labrum is nothing but the fibrocartilage. It deepens the acetabulum. It is attached to the rim of the acetabulum and transverse acetabular ligament. This acetabular labrum forms a tight fit around the neck of the femur. Functions of the acetabular labrum are: it deepens the cavity, it maintains the bony contact, and protects the edges of the acetabulum. Fibrous capsule of the hip joint is strong and surrounds the joint tightly. It is attached medially to the margins of the acetabulum and laterally to the femur. Attachment of the fibrous capsule on the femur. Anteriorly, it is attached to the intertrochanteric line. The entire anterior surface of the neck of the femur is intracapsular. Posteriorly, this fibrous capsule is attached to the posterior surface of the neck, a short distance medial to the intertrochanteric crest. So the posterior surface is partly intracapsular. Remember, the whole of the anterior surface of the neck of the femur is intracapsular, while the posterior surface of the neck of the femur is partly intracapsular. Capsule is thick anterosuperiorly, where the maximal stress occurs in standing position. Postero-inferiorly, it is thin and loosely attached. Capsular fibers are arranged in two sets, superficial fibers and the deep fibers. Superficial fibers are longitudinal, so they are known as longitudinal superficial outer fibers. Circular and the inner fibers are known as circular deep fibers. Circular deep fibers, they form the ring surrounding the neck of the femur. Here is the ring formed by the circular fibers, which is known as the zona orbicularis. So these circular fibers, they form the ring, and that ring is known as the zona orbicularis. It forms a tight collar for the neck of the femur. Longitudinal superficial fibers. Reticuli are long fibers on anterior surface of the neck. These longitudinal superficial fibers, they are known as the reticuli because they are the long fibers, therefore they are known as reticuli. They are present on the anterior surface of the neck here. They originate from the capsular attachment to the intertrochanteric line. They run towards the femoral head in close contact with the anterior surface of the femoral neck. Functions. These longitudinal superficial fibers support the retinacular arteries running towards the head. In the diagram, you can nicely appreciate these are the retinacular arteries, and these retinacular arteries are supported by the longitudinal superficial fibers. Coming to the synovial membrane, it lines the inner surface of the fibrous capsule. It covers the intracapsular portion of the femoral neck, acetabular labrum, transverse acetabular ligament, ligamentum teres, and fat in the acetabular fossa. So in the diagram, you can appreciate this is synovial membrane here and here. Coming to the ligaments of the hip joint, iliofemoral ligament, pivofemoral ligament, ischiofemoral ligament, ligament of head of femur, which is also known as the ligamentum teres femoris, and round ligament of the femur, acetabular labrum, and transverse acetabular ligament. So in total, there are 6 ligaments of the hip joint. First, we will consider about the iliofemoral ligament, which is inverted Y-shaped. It lies anteriorly and intimately blended with the capsule of the hip joint. Apex is attached to the lower half of the anterior inferior iliac spine and the area between it and the acetabular margin. Base of the iliofemoral ligament is attached to the intertrochanteric line. This iliofemoral ligament consists of 3 parts: lateral thick band, medial thick band, and central part which is thin. So lateral part which is thick, intermediate or the central part which is thin, and the medial part which is thick. So 3 bands are there, or you can say the 3 parts of the iliofemoral ligament: lateral band, central band or the intermediate band, and the medial band. And here you can appreciate the attachment. Here is the anterior inferior iliac spine. Apex is attached to the anterior inferior iliac spine, and the base is attached to the intertrochanteric line. Okay. Here also you can appreciate iliofemoral ligament. In this also you can appreciate Y-shaped iliofemoral ligament. This is the cadaveric specimen showing the iliofemoral ligament. Okay. Now coming to the functions of the iliofemoral ligament, it adds strength to the capsule. It prevents excessive extension of the hip joint. During the erect posture, it helps to balance the pelvis. Lateral limb of the iliofemoral ligament prevents the excessive adduction, while the medial limb prevents the excessive abduction. These are the functions of the iliofemoral ligament. Coming to the pubofemoral ligament, it is triangular in shape with the base above and the apex below. It presents inferomedially. Here you can see the pubofemoral ligament, green color. Inferiorly, it blends with the capsule and the deep surface of the medial band of the iliofemoral ligament. Functions of the pubofemoral ligaments are: it limits the abduction and the lateral rotation of the thigh. It supports the joint inferomedially. Okay, so here is the pubofemoral ligament. In this diagram also, you can nicely appreciate pubofemoral ligament, which is triangular in shape. Okay, and it is blending with the iliofemoral ligament. Now coming to the ischiofemoral ligament, it is weak. It reinforces joint posteriorly. Fibers are twisted. It is attached to the ischium below, lower margin of the acetabulum. From these fibers spiral superolaterally to merge with the capsule. Okay, so here is the ischiofemoral ligament. The main function of the ischiofemoral ligament is to prevent the excessive medial rotation. So the ischiofemoral ligament is weak. It reinforces the joint posteriorly. Fibers of the ischiofemoral ligaments are twisted. It is attached to the ischium below the lower margin of the acetabulum, and fibers are spiral superolaterally to merge with the capsule. Okay, and it prevents the excessive medial rotation. So here you can appreciate the ischiofemoral ligament. Here is the acetabular ring and the spiraling of the fibers of the ischiofemoral ligament. Okay. Again, here you can see the various ligaments. Transverse acetabular ligament, it converts the acetabular notch into the acetabular foramen, through which pass the acetabular branch of the obturator artery, medial circumflex femoral artery, and branch of the anterior division of the obturator nerve. So the transverse acetabular ligament converts the acetabular notch into the acetabular foramen, and through this foramen, acetabular branch of the obturator artery and the medial circumflex femoral artery passes along with the branch of the anterior division of the obturator nerve. Ligament of the head of the femur, or the round ligament, or the ligamentum teres. It is triangular in shape, ensheathed by the synovial membrane. Here you can see the ligament of the head of the femur, which is triangular in shape. It extends from the acetabular notch to the fovea on the head of the femur. So here is the fovea of the head of the femur. It carries the articular vessels and the nerves to the head of the femur. Here is the ligament of the head of the femur. Okay. Coming to the movements, it occurs around, movements of the hip joint occurs around 3 axes. Transverse axis, anteroposterior axis, and the vertical axis. Possible movements in the hip joints are flexion, extension, abduction, adduction, external and the internal rotation, and the circumflexion. Flexion and extension. It occurs around the transverse axis. Range of flexion is greater than the extension. Flexion is limited when the anterior surface of the thigh touches the anterior abdominal wall. Remember, the flexion of the hip joint is limited when the anterior surface of the thigh touches the anterior abdominal wall. Extension is limited when the thigh and the trunk are in same vertical position. So in this diagram, you can see the flexion and the extension. Range of the flexion is 110 to 130 degree, while the range of the extension is 30 degree. Hip flexors are muscles that flex the femur at the acetabulo-femoral joint, psoas major, iliacus, rectus femoris, sartorius, pectineus, and the tensor fasciae latae. Hip extensors: gluteus maximus, semitendinosus, semimembranosus, bicep femoris, and the accessory muscles are adductor magnus and the gluteus medius. Adduction and abduction, it occurs around the anteroposterior axis. Adduction is limited by the contact with the opposite thigh. Abduction, in abduction, thigh moves laterally. It is very crucial during the walking. Main muscles which produce the adduction are adductor longus, adductor brevis, and adductor magnus. Accessory muscles are pectineus and the gracilis. Abduction is produced by gluteus medius and the minimus, and it is assisted by the tensor fasciae latae. The range of abduction is 0 to 45 degree, and the range of adduction is 0 to 25 degree. In this diagram, you can see the abduction and the adduction. Medial rotation around the vertical axis. Axis of rotation does not pass through the shaft of the femur because of the presence of the neck shaft angle. It passes through the head and the lateral condyle of the femur when the limb is on the ground. During the medial rotation, the medial condyle of the femur turns backward with the consequent forward movement of the greater trochanter. So, during the medial rotation, medial condyle of the femur turns backward, while there is a forward movement of the greater trochanter. In lateral rotation, the lateral condyle of the femur moves backward with the backward movement of the greater trochanter. So, medial rotation mainly produced by the gluteus medius and the minimus and assisted by the tensor fasciae latae muscle. Lateral rotation occurs because of the obturator externus and the internus, and the two gemella along with the quadratus femoris. Accessory muscles for the lateral rotation are piriformis, gluteus maximus, and the sartorius. So the lateral rotators of the hip joint are obturator externus, obturator internus, superior gemella, inferior gemella, and quadratus femoris. These are the lateral rotators of the hip joint. So the medial rotation occurs up to 40 degree. Range of the lateral external rotation or the lateral rotation is 45 degree. Circumduction is nothing but the sequential contraction of all muscles responsible for the above movements, that is flexion, extension, abduction, adduction, and the lateral rotation and the medial rotation. Coming to the arterial supply of the hip joint, acetabular branch of the obturator artery and the medial circumflex femoral artery. These are the main branches which supply the femoral head around the fovea. Rest of the head and the neck receives blood from the arterial circle around the capsular attachment, in which the medial circumflex femoral artery is the main artery. Though it is arising in the anterior compartment of the thigh, it passes backward and supplies the hip joint. Okay. Reticular arteries arise from the vascular ring, then pierce the capsule and run along the neck of the femur. Here you can see the reticular arteries arising from the vascular ring and pierces the capsule and runs along the neck of the femur. Arterial supply of the head and the neck solely depends on the reticular artery. Rupture of these arteries result in the avascular necrosis of the head of the femur. So the blood supply of the hip joint is very important. Nerve supply. It is supplied by the femoral nerve via the branch to the rectus femoris. Anterior division of the obturator nerve, branch from the superior gluteal nerve and the nerve to the quadratus femoris. Coming to the clinical anatomy of the hip joint. Congenital dislocation, known as the developmental dysplasia of the hip joint. It occurs when the hip joint does not develop properly in utero. That means in the intrauterine line. In this case, acquired dislocation usually occurs as a result of trauma. It may be posterior dislocation or the anterior dislocation, which is very rare. It occurs as a consequence of the traumatic extension. So dislocations are two types, congenital dislocation and the acquired dislocation. Congenital dislocation is also known as the developmental dysplasia of the hip joint. It occurs because of hip joint does not develop properly during the intrauterine line. Okay. In the acquired dislocation, which occurs because of the trauma, and posterior dislocation is very common in the acquired dislocation, and anterior dislocation is very rare. Perthes disease. In this disease, there is destruction or the flattening of the head of the femur with an increased joint space in the X-ray. Osteoarthritis occurs because of the old age. Fracture of the neck of the femur, trochanteric fracture, and diseases of the hip joint. In India, mainly the tuberculosis is very common. Coming to the fracture of the neck, there are various causes of the fracture of the neck. The important ones are, it occurs in the elderly people because of the osteoporotic changes, postmenopausal women, and indirect violence. These are the three main important reasons for the fracture of femur. There are two types of fracture of neck of femur. One is intracapsular and the second one is the extracapsular. In intracapsular fracture, retinacular arteries are injured, leading to delay or non-union of the fracture. Serious complication is avascular necrosis of the head with the result of loss of function of the hip joint. In this case, features are shortening of the affected limb. Limb is held in laterally rotated position. So, from the observation, you can diagnose whether there is a intracapsular fracture is present or not. Okay, there is shortening of the affected limb and the limb is held in laterally rotated position. Extracapsular fracture is relatively less serious because of the retinacular arteries are saved. Coming to the neck shaft angle or the angle of inclination. It is the angle between the shaft of the neck, between the axis of the neck and the shaft of the femur. It is more in infancy and decreases progressively to reach the value of 125 degree at the puberty, and after that it is fixed. In children, the value of the neck shaft angle is 160 degree. Once the growth is complete, no further changes are noted in the neck shaft angle. When it increases, it is known as the coxa valga. So when the neck shaft angle increases, it is known as the coxa valga. It is found in congenital dislocation of the hip joint and it limits the adduction. When the neck shaft angle is reduced, it is known as the coxa vara. It is seen in the fracture of the neck femur and it limits the abduction. So the neck chap angle or the angle of inclination is more in infancy and it decreases progressively to reach the value of 125 degree at the puberty. So the value of the neck shaft angle is 125 degree in the adults and in the children's it is 160 degree. And once the growth is complete, there is no further changes are noted in the neck shaft angle. And there are two entities important in relation with the neck shaft angle. One is coxa valga, in which there is increase in the neck shaft angle. And when there is reduction in the neck shaft angle, it is known as the coxa vara. So here is the coxa valga and coxa norma, that means it is normal, and coxa vara. So thank you. This is all about the hip joint. You may get full question on the hip joint, short notes on the ligaments, various ligaments of the hip joint. Then you get the short note on the acetabular labrum. Then you get the short note on the lateral rotators of the hip joint, neck shaft angle or the angle of inclination. In this way, the questions are asked on the hip joint. Thank you very much.